think this is my last talk for today. I won't bore you after this. Tomorrow we have a hands-on we'll discuss. So in this, basically, I'm going to give you an overview of what we have been doing in our lab in the space of generative models and digital health, and using machine learning for machine learning for and artificial intelligence for healthcare. And the idea is essentially here to give a more broader picture. These are broader strokes of what we have been doing, because this audience is quite diverse and spread across disciplines within clinical biological sciences. So I'll just give the broader strokes of what kind of research that we have been engaged in, what are the possibilities in going forward, what are the areas that are becoming very important. At the risk of skipping some of the details, if you are in each of these studies that I'm going to be presenting. So if you have any questions, please do feel free to prompt me in between, and I'll be happy to take the questions. So this, why is AI/ML in healthcare important, right? So if you look back, now we are beyond COVID, but if you read the title of this, the date of this is 26th of January 2020. And the article in Wired says an AI epidemiologist sent the first warnings of the Wuhan virus. And you can see that at that point of time, it was still not called COVID-19. It was still not called, we still didn't know that it was a coronavirus, right? So it was called the Wuhan virus. And the algorithm that did this 10 days before the WHO alerted the world was the blue dot algorithm from a company, the blue dot company, which basically is based in Canada. And the founder of this company is Kamran Khan, who is a pediatrician by training and data scientist. So I'm just trying to make a point here that it is so important that we create the bridge between healthcare and data science and have the people like yourselves getting trained at the interface of both healthcare and data science. So this algorithm was not just a news flash story, because they have been doing this. You can see the name here, Kamran Khan. They have been doing this not only for COVID, but they've also been doing this, for example, for Zika and Ebola, and then for COVID-19. And the way they were able to predict COVID-19 as a pandemic ahead of time, before, as I said, 10 days before WHO alerted, was by looking at very large sets of data, both structured and unstructured flights, data, etc., to create algorithms that were able to anticipate the emergence of the pandemic. So that was just a brief on why we need, even in today's world, why it is becoming very important to have machine learning expertise built into healthcare and vice versa. Okay, so machine learning in theory, if we have to build such algorithms, it might look like what they might have done is select some model, use some training data, build the model, test the model on evaluation data, and apply it to the task. But in the real world, this is not usually the case, right? The real world MLAI does not work like this, especially in the public health and clinical settings, because although computer scientists, I'm also teaching in the Computer Science Institute, so we like to think of world like this, in a very well-engineered system with very well-known coupling constants and building blocks that can be characterized and parameterized. The real world is actually like this, which has very loose couplings. They are adaptive. They evolve over time. Imagine a patient who can respond in any which way when they are in an ICU setting, right? So we have to learn models that are, you got some sense of models that are complex in nature, can work with complex data sets, can work with complex couplings, and they capture the essence of the mechanism that is going on, right? That is the place where generative models come in. Many times, I think many of you also asked it after the last talk, that if can I use this model for classification, Bayesian networks for classification? Yes, you can, but by themselves, they are not the best models for classification. They are the best models to understand mechanisms. However, you can then build upon those models as for classification. Same with transformer models, right? You want to fine tune those models to a certain task to achieve a certain classification outcome. But we want to understand first and then predict, right? And in healthcare, that is the part that is largely lacking. We don't understand a lot of physiology in healthcare. We don't understand a lot of genomics, a lot of couplings, etc. It's a famous joke in medicine that 50% of what is in our medical textbooks is wrong, and we don't know which 50% is wrong. So, I mean, the situation is not that bad, but it just goes to show that our knowledge constantly keeps on evolving and needs to really get updated. So our lab basically solves and tries to solve these challenges that exist in the real world. The first is a data gap, that we don't have enough data sets in healthcare. So how can we create platforms that actually enable whatever data sets are there? We can enable working with those data. So we create data platforms. I'll talk about one of those later. We also know that data are time-consuming process. So how can we enable processes that can make data easier? And there's a knowledge gap. Once we have data, we have to basically solve some challenges, but that requires the skills that are lacking right now. So we skill people, right? We train them and bridge their understanding, but we also generate new knowledge. For example, the kind of models that I showed earlier are knowledge generation models. Finally, policy gap, and I place that at the top, because unless we can make some change in the way things are currently done, knowledge and data are useless, right? Because what will knowledge do if we can't influence any decisions in the ICU or decisions in the public health settings, right? So, I mean, I'm not discrediting knowledge, but the whole point is that in our lab, we have a lot of emphasis on how do we move towards interventions? How do we move towards decisions and making prediction models that can effect a change? So I'll start with some examples, starting with ICUs. I noticed at the end, I think there was some hodgepodge in the slide arrangement, but bear with me if that happens. So the first project that I'm going to talk about, the first case study that I'm going to talk about is Safe ICU case study. And that highlights all the three gaps: the data, knowledge, and the policy gap. We started this project in 2015 at All India Institute of Medical Sciences, supported by the Wellcome Trust India Alliance. We recognized that there is a strong potential for artificial intelligence to help decisions in the ICUs. Why? Because life-threatening situations happen in the ICUs. There's often a window of opportunity between which, for example, this baby might develop sepsis, right? And there may be some delay in recognition of sepsis. And there's a window of opportunity which doesn't last beyond 6 hours, after which the organs may start failing, 6 to 12 hours, right? So, but there is a window of opportunity where if interventions can be done, like start antibiotics, give more fluids, right? You will actually be able to save the baby. So we said that the ICU actually generates, it's an 8-bedded ICU, pediatric ICU at AIIMS. This study is in collaboration with Dr. Rakesh Lodha, who's the chief of the pediatric ICU. Without him, this whole thing would not have been possible at all. So I basically owe this all kind of work to his collaboration. So, but we went in and basically said that there's a gigabyte of data that gets generated in the pediatric ICU every day. Gigabyte generated and gigabyte lost every day, because every next day it gets overwritten. So can we build models that will work with these kind of data to build predictive models that can then enable decisions? What are these data sets? As you know, when the patient gets admitted to an ICU, they get plugged onto these machines, which will measure the heart rate, pulse rate, oxygen saturation, respiratory rate, um, blood pressures, and so on. Standard things. Now we are, after COVID, we know all these things, right? So we put in systems, software that we wrote ourselves, again, emphasizing the data gap. Sometimes we don't recognize that there is a data gap, or there is a data opportunity, I would say. By just putting in our own software systems that we wrote to connect these monitors and get the data out, so far we have actually, now this number is actually higher, more than 2 million patient hours of continuously monitored data from the pediatric ICU at AIIMS every second that comes to our data systems. We call it the SAFE ICU, Sepsis Advanced Forecasting Engine Initiative. So we started actually simply, we didn't start with these predictive models, but today we are talking machine learning. We actually started by building value for the clinicians. Simpler things, not these kind of models, simpler things which showed how much is the oxygen saturation, how much is the time in which the baby was in the right oxygen saturation range. Because we know that in premature babies, if the baby is below 88, obviously they are getting less oxygen, they'll develop organ failures and hypoxia. But if they're given more oxygen beyond 95% saturation, their retinas are so sensitive to oxidative stress that they'll go blind. So there's a need to keep babies in the right oxygen saturation range. How is it traditionally done? A nurse will go every 30 minutes and check if the baby is in the right oxygen saturation range and change the oxygen settings. But can we be more proactive? Can we look at these data and keep showing these data at least? And as a quality monitoring study, we started with that initiative where how much time is the baby spending in the right oxygen saturation range as a quality initiative that was deployed. What helped? What did that help? That helped us build trust in the pediatric ICU and the neonatal ICU. Doctors started realizing the value of big data. If we went in and said, oh, we have to build these AI models that will predict sepsis and shock, they probably are never going to be excited about the whole thing because first show me the value, right? Then we started building models like these where we started looking at small data sets coming from thermal images and these signals. Why thermal images? It was just a chance occurrence that one of my friends from MIT was visiting and he said, here is a smartphone attachable thermal camera that you can use. What can you do with it? And the first thing that came to my mind was shock. In first year medical school, in physiology classes, we are taught that if the hands and feet are cold and the center is warm, think shock. Because in shock is a condition where there's a mismatch between oxygen demand and supply. Oxygen needs to go to brain more than it needs to go to skin, right? In cases, in situations where there's such a mismatch, right? So what happens that when the patient is going into a critical situation, more blood flow is diverted to critical organs like the heart, brain, and then is diverted away from organs like skin. So we said, can we incorporate this domain knowledge, domain understanding into our models? No deep learning models, very simple image-based models, computer vision-based models, which looked at features called histograms of oriented gradients to capture where is the baby's foot in this image and where is the baby's abdomen. Not such a difficult problem, but it's difficult because of the quality of thermal images. You can see the thermal images are not so sharp, right? But we were able to actually solve that using our simpler computer vision models because we didn't have a large million data set to start with, right? But that gave us a proof of concept that there was, and this was all automated, calculating the gradient between these body parts, which was then shown to be in a model predictive up to 12 hours ahead of time of shock in the ICU. So this was our first sort of a computer vision based analysis that gave us an indication that these can be useful. Now we have, as a follow-up paper after this, there have been a couple more papers that have been published, which have used thermal videos as a modality and doing that using deep learning models, as you would expect. Now we have larger data sets. So we went the deep learning way and basically built models. predicting critical outcomes, achieving more than 80% PPV. Is 80% good? That's a question that we usually get. And our standard answer is it is 80% not of detection. Unlike we say this is a chest radiograph and 80% probability that there's tuberculosis in this X-ray, we're talking about the future, 12 hours ahead of time. And if we compare it with doctors' predictions, they are definitely better than what we are able to achieve. So some of our models, I'm trying to be brief here, so there may be some leaps, but as I said earlier, some of our models basically based on vitals have been validated in more than 200 ICUs, mostly ICUs in the US settings because we don't have access to other data from India. If you are working with ICUs and would like to collaborate, I would be very much excited. But you can see that in more than 200 ICUs, our models are achieving more than 90% accuracy. And these ICUs include adult ICUs, cardiac surgical, cardiothoracic, medical, surgical, neuro, surgical ICU, etc. This paper is under revision in the high impact journal. So, but we are keeping our fingers crossed. So what we show is essentially that as we get more and more data from the patient in the ICU, our predictions about their future outcomes actually becomes very strong. So the key insight here was we were able to transfer the model from a completely different setting, which was the US ICUs, to the Indian pediatric ICU. There's no child ICU here. So we were able to learn from a setting which was completely different in the US and transfer our learning to an Indian ICU and still get more than 90% accuracy. And that's one of the key selling points of the paper about learning generalizable models that would generalize across settings. And then, of course, we prospectively validated it. That's the second key point. Many of you asked, which is the model, which is the best model? I say the best model is the one that prospectively performs and is generalizable, which means that if the model performs today, it performs consistently across time and performs across sites also. Right, so that's our definition. It's not our definition, but most of the machine learning community is now waking up to the fact that we should stop evaluating models for 80%, 90% accuracy and the best model. We should start evaluating for outcomes and also looking at prospective validation and generalizability. So I think that was models are explainable XAI, explainable AI. As you can see, they are capturing some of the important features that you would recognize here, which are important for sure. This is another paper. This is a slightly older slide. It's submitted already, but this is a paper that we have submitted on a cohort called Dennis cohort, New Delhi sepsis study in neonatal sepsis. And this study was across 5 different hospitals in Delhi, AIIMS New Delhi, Maulana Azad, Safdarjung, LNJP, and one more. So essentially what we did here was we are looking at early onset sepsis, which is EOS, and building prediction models for it. Here, since it's a multicentric study with very different characteristics of ICUs, we did not have these large, big data with millions of patient hours, but we had a standardized questionnaire-based and clinical evaluation-based assessment of these patients. So basically, we were able to build models that were capturing these features which are predictive in nature, right? And build a dashboard out of it for these sites, which is currently running. And you can see these features are mostly explainable for both early onset and late onset sepsis. So again, simpler. I think there was one slide which I missed. Yeah. So these are the features. As you can see, there's prior probabilities of sepsis for each of these sites, which is AIIMS, MAMC, Safdarjung, and so on, which gets accounted for in the model, and then you fill this on the site, and basically it calculates the outcome probability for sepsis in this patient. Again, this is a multicentric model and is live, currently under submission. How to incorporate patient history in all of this? We use language models. These are another type of generative models, which you are probably aware of from the recent hype about ChatGPT, which is again a language model which can actually understand language. use language models as a feature to also incorporate into our ICU predictions. And the message from this, that in short that I'm sharing, is that incorporating patient history actually improves the outcomes as well. And that can be done using language models in combination with time series models, as we showed earlier. So these are some of the language features that we see in these models. For example, whether the patient is on insulin or not is a good predictor for whether the patient might go into shock or not. Profiling these models for different patient types, just like Bayesian condition probabilities, how well does the model perform for patients who are in hypertension and congestive heart failure and anemia and so on. So we show that mostly these models are performing quite well across disease contexts and treatment contexts. So that was our Safe ICU initiative. Now, next I'm going to talk about the models that have been we have built for public health and that have indicated some decisions that can be taken around public health. This started way back in 2013 when I was analyzing the data which was shared with us by Chest Research Foundation, Pune, and they had collected data from 200,000 patients on a single day all across India. It was a point prevalence data done in collaboration with CIPLA. Simple data set, having a questionnaire of about 65 questions, which were ICD-10 validated. ICD-10 is International Classification of Diseases, like anemia, yes, no, asthma, yes, no, and so on, right? But you can see that the data were collected all across India. This was a geographic spread of data collection, 2 lakh patients. And the question I started asking at that point of time in 2013, which was later published in Lancet Global Health, was, can we start doing these networks analysis and then obviously the Bayesian networks analysis? So you can see the association network here, which does not have an edge, to find communities, because we know that diseases don't happen in isolation, they happen together. There can be communities of diseases that can be happening together, and then basically go on to build some decisions. So we saw that, yes, we found that each node here, it was a, for example, this is a symptom, fatigue, right? It would be connected to something which is related, maybe myalgia or something, right? So, but you see that there's a community of nodes here, which was detected by algorithms, community mining algorithms, which were then basically plotted as a community network and tracked longitudinally, okay? So each node here is a community, and that maps to each streamline here, okay? So each community, so it shows that the respiratory signs and symptoms, community of symptoms, is actually the most important complaint with which patients visited the doctors on that single day across all age groups. So it's a pseudo longitudinal analysis, it's not longitudinal. So you can see 0 to 10, more than 60 age group. So, I mean, cough and cold is the most obvious complaint, right? So not so interesting, but look at female genital complaints. They became important. The more important it is, the more heavier it becomes and it settles down. These become important in the reproductive age group. More importantly, in the community, they come together with anemia. In the network, they come together with anemia, they stay together, and then they separate out. Circulatory symptoms become important, combined with diabetes in this age group, and then they stay together. Male genital complaints stay up there, and they become important, and then they combine with urological, which is benign prostate hypertrophy at this age. So this gave us a good visualization of what was going on in the Indian population on a cross-sectional kind of a one-day point prevalence study. But then we went on to actually build a Bayesian network of the kind that we were discussing earlier, asking a question: what if I actually put this data in the context of which district is the patient coming from, right? So we actually pulled out the district level indicators, which were so many indicators, which included things like what was the education rate and so on. What we find in a completely agnostic fashion, that the LPG consumption across the district was a parent node of obstructive airway disease and meningitis, right? And we thought it was a fluke, but then we bootstrapped, we found it to be persistent. And then basically we see that since we can do inference, we see that if we increased LPG penetration, we would decrease the level of obstructive airway disease by half in the districts. Clean cooking fuel is an important thing. If we are not using clean cooking fuel, we are burning firewood or chullas, right? So essentially, this was one of the first evidence that why it's important to include. But more importantly, it actually gave us a validation of the fact that we can contextualize our models on the background of, for example, social demographic indicators. And we kept doing that over and over again for many papers that I'll be briefly talking about. So the second case study, I think, yeah. So the second case study that we used Bayesian network for such kind of a contextualization was work that I did when I was at Stanford, basically looking at the health inequities in the United States, right? So the richest American men live 15 years more than the poorest. This is known data. The richest American women live 10 years longer than the poorest American women. So there's a very clear health disparity in the United States. And there's a lot of talk about AI increasing these disparities, right? So we asked the opposite question: can AI, which is explainable and of the sort that we have discussed today, actually give us insights about reducing these disparities? And they impose a huge burden of more than $300 billion per year in the US. And we said that longevity is a good indicator of health outcomes, which is sum total influence on healthcare, right? So a longevity gap, which is this, is a good outcome to be looking at if we want to look at what social demographic factors would play. And this was published in IIII, which is one of the top AI conferences, as a full paper. We also deployed this as a dashboard. So the key messages, I know we are running short of time, the key messages were that diversity actually mitigates the longevity gap in the US. And that's what we found in a setting which was more causal. We did not do a more association-based analysis here. We actually did a more causal kind of an analysis, right? So counties which were having high diversity were 38% less likely to have a longevity gap between the richest and the poorest. And the data integrated were mortality, healthcare, demographics, education, socioeconomics, and so on, even taxation and social cohesion. These data were maintained by Stanford by a group. So, and then we had other things like quality of primary care. Even in the United States, we think about primary care in India, but even within the United States, where the care is still quite good, we see that there's still a gap, and counties with high primary quality care, not just visits, but investigations. And why we were able to say this? Because from the network, we were able to see investigations that actually contribute. Have a 43% increase in probability of living beyond 85, right? And acute mortality also was an outcome. And then there were some usual suspects like smoking, education, exercise, which influenced longevity. So this basically, and there was also this, I think, interesting finding about family stability, which indirectly led to crime rate and upward social mobility and increased Gini disparity in counties. But this was all inferred from one model. And now you know what kind of model we are talking about. So here are the variables: life expectancy, disparity, and then there are the other variables. For example, there is percentage born foreign population in that county. And you can see there was a direct link there and a causal and a direction. And that's how we started exploring. So basically, that's where we got these messages from. This message comes from this part of the network, right? So, and we did find some explanations for why this may be happening. We did find that higher diversity counties were having higher household incomes, particularly from females. And that basically was the explaining factor. And that was all inferred from the explainability of the network. And this was a bootstrap network, more than 501 bootstraps, so we had confidence on this. Then there was also temporal causality, because we were looking at variables between certain time periods. So we allowed that to also play out. But yeah, so I'll skip these features which I've already talked about: preventive care, which primary care investigation had the most impact. It was the annual lipid testing, right? So we were able to actually point out that if we increase the amongst the investigations that we could do, like eye exam, mammogram, lipid testing, what would have the highest payoff for decreasing the longevity gap? We found that the lipid exam had the highest payoff. This is all available in the paper as well as in the net. So I'll skip these messages, which are usual suspects, but you can explore the paper. And we were able to deploy these models as a dashboard also, which, by the way, tomorrow you'll learn that you can do that directly in IISER as well. More recently, we have used this kind of work in addressing the antibiotic resistance, antimicrobial resistance across India. This paper is currently under review, so I'll not talk a lot about it, but in collaboration with ICMR, 20 different sites, we show what are the trends and associations of antibiotic resistance over the last 5 years across India, and how is it situated in the context of sustainable development goals. The message that I'll give away is that AMR we found in our network, and we quantified how much tightly it is linked to the sustainable development goal achievement, and it's an important factor in mitigating the non-achievement of SDGs across. Okay, so let's now come to, I think we have 20 more minutes. So go to the third leg of case studies, where I'll be talking about generative models, which may be the most exciting to some of you, which are language models. Same models that ChatGPT uses. These are called large language models, right? But we'll start with something called vector space models, which are just as an introduction to large language models. The key idea here is that language cannot be understood by the computer directly, but we want to represent the language as some mathematical quantities, right? And what are those mathematical quantities? These are vectors. And from high school algebra, you may remember that vectors have a magnitude and a direction, and they can be added, subtracted, and multiplied. So if somehow we are able to represent words, or in general tokens, as vectors, we can actually do algebra with words, right? So we can start adding words, subtracting words. That is how ChatGPT is actually generating new language. It takes 2 word vectors and predicts what is the next possible word vector that would emerge, right? So basically, these are models that construct such vector representations. I'll not go into a lot of detail background teaching about these, but I'll just talk about the 2 or 3 variants that are available. The simplest word vector models are called word-to-vec, which basically are trained by looking at the context of a certain word. For example, the quick brown fox jumped over the lazy dog. You can look at the word jumped and try to predict it by looking at its surrounding words, right? Predict the middle word given the context. This is called continuous bag of words variant. There's the other approach. These are models which were made publicly available by Google. These are not our models. These are called word-to-vec models. So I'll skip these technical details, but essentially you're predicting one word here by looking at the surrounding words, right? And this is a large neural network, but you learn, in the process, you learn the vector representations, which is in this hidden layer. So for each word, you learn what is the representation or the underlying representation of the word in the vector space, right? They also do something called the skip-gram variant, where you predict the surrounding words given the middle word, and that's also a very successful model. So we used, I'll skip this. You see that you're using one word to predict the surrounding words, right? And the architecture is slightly different from earlier. But we use this approach to start looking at the COVID-19 genome. We said that genomes are also essentially documents. They consist of words. Here we not letters, but words which are codons. So we started representing codons as vectors using language models. We have still not gotten to large language models. We are just using language models. This was published last year, but I mean, this is some background mutation probability in the COVID-19 spike region. And you can see that there's some places where there's mutations that happen more frequently. But what do the large language models or the language models would capture is that what are the relationships between these mutations, right? So just as we say that if I'm speaking language, right, there's a relationship between words, the way language flows, right? There's a noun, adjective, noun, verb kind of a flow in language, right? But can we learn that kind of thing directly from data? So that's how do mutations happen together and can be used was what we were asking. Here is an example of a codon, right? We learn a skipgram model using, you may ask that Google trained these models on Google News. It has no relationship with genomic sequences. So, but what we found that we had 3 million sequences to train with, so that large number of sequences, COVID-19 sequences coming from all across the globe, were able to train a model that captured the phylogenetic distribution of the variants. I think some of you know what that means, that basically in time and in space, we were looking at the relatedness of these variants, and that was captured very nicely by our model. How? Because we can calculate the distance between two documents, which is genomes, by using something called cosine distance in our case. Because we are having vectors, we can look at cosine distance and calculate those distances. We showed for out of 17 countries that 7 countries, I think that's the next slide, maybe it's coming up next, I think somewhere. In more than 7, I think out of 17, 7 countries showed significant association between some features, which are entropy of these grammars that were learned and the number of cases. So you can see that you can think about this line as the entropy of a certain grammar. How quickly is that dimension changing for COVID-19? So COVID-19 grammar is changing. Think of that way. But we are capturing 36 different dimensions in which some dimensions are able to lead the number of cases. And that happened consistently across many countries, which means that we were able to predict 2 months ahead of time that a surge is likely, just by looking at the way certain dimensions were changing in the grammar of COVID-19 sequences. And this is the overall flow. More than 3 million sequences were used. Temporal analysis also proved the same thing. Just quickly jump to, we've already discussed qualitative analysis. Countries that were together in space were also closer in their grammar space of word-to-vector representations. So that's some qualitative analysis. Then we did some statistical analysis, which basically I was just talking about these countries. We see significance at statistical level, as well as this is a detrended cross-correlation analysis, which shows that some dimensions like these blue lines are leading exactly 2 months ahead of time the cases. Why is that happening? Because the virus is actually exploring a set of mutations. And once it finds those mutations, it exploits them. The explore-exploit paradigm is playing out here. So once it explores, first it explores and then it starts exploiting, and that's when the cases go up. That's a reasoning that we have for this, and that was evident in all these countries and was able to predict the outcomes. And also in machine learning, it was able to pick up the same dimension, which we captured in statistical and BCCA analysis. Again, reinforcing that there is value in looking at the generative space of COVID-19 sequences to predict what is happening at the public health and epidemiological level. These are interpretable. You can go back at the paper to look at the paper, and basically these are the same sort of mutations that were reported by experts also, but now we are basically providing a look ahead time, which is not possible otherwise. So I skip these mutations and so on. It was created into a dashboard which still runs, but now we are actually moving the transformer models to this place. And this dashboard was active throughout whenever there were peaks of the COVID-19 virus, and we were able to predict. So that brings us to another generative aspect, which is transformers. I will not be able to go into a lot of detail, but and skip all these details about transformers, which I refer to this paper, Attention is All You Need, the famous paper from Google Brain, which transformed all the space of language modeling. But essentially, the idea is that you can pay attention to the whole sentence and make a prediction about a word. You don't need to look at a single word and its context, but look at the whole sentence. So which means that these give us a long range understanding of what is happening in language. And more details are there in the paper, which we'll not be able to discuss. But I'll just give this example. The animal didn't cross the street because it was too tired, right? The model is using, how does it know that it is referring to animal? That is happening through attention mechanism that I just alluded to in the previous slide, right? If you change just one word here, the animal didn't cross the street because it was too wide. Instead of tired, too wide. You can see it is now referring to the street because it is street. It was too wide. So this is being learned in the neural network that learns the attention mechanism. What it allows us to do is, it allows us to tell that if I now think about this as genomes, if I make a change in genome here, where would the most attention go to? Maybe the other places where most of the changes are also happening, right? So it gives us a tool to basically understand the genomes better and also to conduct experiments with genome, has implications for drug discovery also. I'll skip all of this. How does this work out? But this is our new paper, which we have not published yet, but will be online soon as a preprint. We call it Strainformer, where we use these 3 million sequences to train a transformer model. We actually understand the biology of evolution of the COVID-19 virus, and then to prepare for the next pandemics as well. Because we showed that this was applicable even to the MERS set of sequences. So the attention has a non-random distribution across the windows, and it captures much more finer grained information than what our previous models were showing across countries. And basically they give us position level changes to the accuracy of 95%. So I can exactly tell what is the nucleotide here if I at any given location, if I change something. So that is the kind of model accuracy we are able to achieve here. And then we are able to actually link it to biophysical properties of the COVID-19. That if I made few changes in the spike region, how would the changes implicate in terms of binding to the AS2 receptor and so on. All possible with models that are based on generative transformer-based architectures, right? So I think we show some properties, which is the most interesting part of the paper, that the model never saw some things which it was able to infer. The model only saw DNA sequences. It doesn't know that there's something called the wobble hypothesis, right? Which means that if the third base changes, it can still code for the same amino acid, right? You were actually able to capture some of these emergent properties which were never obvious from the input data. That's why they are called emergent properties. That the model could infer about, for example, synonymous and non-synonymous variations, and even their binding energy changes. So that to us is very exciting, that these models are not just hashing some features in the sequence, they're developing some quote unquote understanding of the biology of the genomic variation, at least in the COVID-19 sequences that we have. That's very exciting to us, and we'll be happy to share more later. So what do these generative models allow us to do is also, for example, I spoke about other data sets, putting in the context of other things like mobility, strains, and health and socioeconomic factors. And that's, we took data from Facebook on mobility, integrated in the context of strain emergence, and also data from ICMR. on testing and data from NFHS to create an integrative picture of the COVID-19 spread across India. So that's ongoing work that we are currently engaged in collaboration with ICMR. So, and this is also ICMR work for antibiotic resistance. I think I will probably, I still have 10 minutes. I want to leave some time for questions, but I'll just make use of next 5 minutes to just say that these models that we developed, language models, were also used to develop a public health messaging system. So way earlier in the pandemic, we started basically engaging with the governments and how do we spread the right information to the right people in the right format at the right time. At the start of the pandemic, there was no right information. So we started looking at the World Health Organization's data sets and what was being shown in the news, use language models of the kind that I just showed you to compare and calculate similarities, summarize them using language models, not by humans, but summarized by language models, matched them, and provided text-to-speech summaries in Hindi and English. This was called Washkaro app. It was released as an Android app on Google Play Store, which basically gave bite-sized audio Hindi and English pieces of information. Idea being that women, for example, who are in villages, why I'm saying women, because obviously the level of education is different. So we had that hypothesis, need to know that information, but they don't know because they are the primary caregivers for their babies and for the family. So that was a kind of feedback loop that we incorporated, that they could give thumbs up or thumbs down also to this information. And we showed that over 3 months, thumbs up and thumbs down led to an improvement on the AI prediction of relevant count of articles. This was published in scientific reports. Basically, we showed that giving thumbs up and thumbs down was important for our AI engine to improve over time to give the right information. We also saw that more females engaged with the app in Hindi than males, which was what our initial hypothesis was, although more males were engaging. These were 11,000 users over 3 months period during which the study was conducted. Then Google changed its policies. It said only government can spread COVID-19 information. So we had to change it from COVID. Now we are doing it for tuberculosis. But the app is still online, and this is the paper that was published. So I think I'll just stop here because there's some other studies. I'll skip some of these and not before I just mention that we, as I said, we solve the data gap. There's a lot of data that gets used in these kind of experiments. And we created this initiative called IFHP, Integrated Federated Health Platform, which actually not only lists the models that I've just described, strain flow model, there's a couple of others that I've not talked about, but also the data sets. Now there's more than 20,000 data sets, which we call COVID-19 Data Common Toolkits. Idea being that there's so much data that's put out, but that never gets used because they are not in a harmonized format. We are now basically harmonizing these data sets using AI and building models on top of these and making them publicly available in a more usable format. So that's the COVID-19 Data Commons Toolkit and available as a community. So to summarize, AI/ML in healthcare, it must be built for nuanced contexts and it must integrate context. The studies that I showed in the beginning, where we are using prior probabilities or Bayesian networks to incorporate, for example, the socio-demographic variables, are an example where you want to incorporate context into your models. The same model will not work everywhere. Context is important. Connect with domain understanding. That's where all these models become really important. Represent and generate knowledge, right? So we must learn to work with data to first represent knowledge and then generate knowledge. Sometimes we forget this part and we directly go to classification, which is also fine, but then we lose on some of these very important pieces of information. Finally, build early feedback from stakeholders. All this work was done in collaboration with either hospitals or with, for example, the Bayesian network kind of work was with NGOs. So we must build early feedback from stakeholders. And I think the one last message which is apparent in all the 3 presentations today from my side is that visualize, interact, iterate. I think it's very important in healthcare. We can't have black box models, and we would like to visualize with explainable AI interact with the model and iterate over the model. Okay, so that's part of my team that contributed to this work that I presented today, and our funders and supporters. Thank you so much.
I have a question in your health equity case study. So there I have seen you have interpreted multiple independent variable for a particular outcome, I think. So can we so you have interpreted the causality thing for multiple independent variable. So can we do that, means using these networks? It's
So in
like
that, what we have
isn't
done is,
it like testing multiple hypotheses or
no, it's actually
yeah.
actually not. It's actually a
It's an
remedy
advantage
against
over that.
it's an advantage over multiple hypotheses, because we are not doing those many independent hypotheses.
Okay.
We are fitting one common model, a
And-
joint probability distribution model, right? We are not doing those multiple hypotheses. And that's the other advantage of these models, which I forgot to iterate, that basically we are not doing these pairwise
Yeah.
tests. We are fitting one model.
And in that one model, you are able to prove causality of multiple independent variable or multiple exposures, right?
Yes.
Okay.
So that is the model that basically, that's how the model looks like, right? And this is life expectancy disparity. And what we did was basically we looked at what are the associations of these, right? For example, percentage born, CS born foreign, right? That was an indicator of diversity. So we started asking, first we thought that this may be a fluke, but after bootstrapping, we saw this persists and with high confidence. And then we go back, okay, what is the, so we were able to actually trace it back, that what was the reason that the percentage born foreign was important. And we find that essentially it was working females and household income. That was, so you were able to actually build that chain of reasoning in this model.
Okay, because in typical epidemiological model, you need to identify the confounders and adjust it for each exposure and the outcome or a primary outcome. But here you can draw multiple inferences using a single network.
Yeah, you have to be careful that when you are drawing these conclusions, are you actually having any confounder? This does not have a confounder.
Yeah.
If I was actually drawing inference on this and it had a confounding variable, I would have to first adjust for that.
Yeah.
Then infer.
Yeah, so it get automatically adjusted with in these networks if you add that particular covariate. It
doesn't get automatically adjusted.
Yeah,
you can see it that there's a confound. For example, this variable is a confounder for these two variables, right? These, if there was a link here, I would say that this is a confounder, right? So you can see this. If I inferred anything between this and this, I would be making a wrong conclusion because I know it's confounded by this particular.
Okay.
So it just makes it more visible. Doesn't automatically correct for it. You can still do inference just as we did on this and this, but that will be a flawed inference.
Okay.
Which other models you'll make that flaw? In this model, you will see it. That
you can visualize that.
You should not be doing that.
Yeah. Thank you.
Thank you. Thank you.